Great. Well, it's my pleasure to be with you today to share some early work about the experiences of a new population of palliative patients, and these are young adults that are aging out of pediatric palliative care. And to date, there's been very little research that has probed the experiences of young adults graduating or transitioning from pediatric palliative care. And this presentation highlights what the young adults with life-threatening conditions shared with me in my research about their experiences transitioning. And I'll also provide some recommendations for alternate and new approaches to their care. You might wonder how this picture of this young man in this slide relates to life-threatening conditions in palliative care. If you did, that's great, because this is the key difference with the population of palliative young adults. They do not fit into current services, practices, and philosophies of adult palliative care that we are more familiar with. So I don't know how to move my slides. How's that? There we go. My interest in young adults with life-threatening conditions was born from observing the beginning of a disconnection. On their 18th birthday, young adults who'd had the opportunity to experience an incredibly connected and supportive network of pediatric health, education, social, and palliative care are disconnected from these resources. These young adults leave behind a palliative approach that's an active and total approach to their care. It embraces their physical, emotional, social, and spiritual needs, but most importantly, it focuses on the enhancement of the quality of life for the child or young person and includes support for the family. In pediatric services, this palliative approach to care is often provided through specialized hospices or palliative centers. I'll be suggesting in this presentation that a palliative approach to care for young adults does not have to be within bricks and mortar institutions. This type of facility would be wonderful, but unlikely feasible and sustainable in the current economic climate, and also considering our vast geography that separates us. In my study, these young adults were between 19 and 30 years of age. They were graduates of BC's Children's Hospital and Canuck Place Children's Hospice. In other work, you might see young adults classified as being anywhere between 16 to 35 years of age, and they're increasingly being referred to in some communities as emergent adults. Young adults with palliative conditions cover a spectrum of young adults, from those with profound developmental delays to those who are able to attend university. Within this spectrum of abilities and needs, approaches to care will vary and certainly require individualization of both the young adults and their families' needs. My study focused on the cognitively competent young adults, but there is much need for research across all facets of this population. The types of conditions that they have include neuromuscular, and for example, Duchenne's muscular dystrophy or spinal muscular atrophy. And as a little picture of these young adults, most of them require 24-hour attendant care. Their independent function may be reduced to minimal movement of only their index finger. It's on a joystick that controls their power wheelchairs, computers, and phones. And if their arm is knocked off their wheelchair control, they may not be able to independently move it back onto their chair. Other conditions for these young adults include metabolic conditions, cancer, rare, and some conditions that have not even got a diagnosis or a name that goes along with them. This young woman has a different type of rare disorder with severe complications, and I just want to read to you her description of herself to give you a more fulsome picture of who these young adults are. She says, "I have a very rare condition with very severe complications. It means I am very bendy. My joints dislocate easily and frequently. I live in chronic pain. My muscles are weak. My autonomic nervous system doesn't work, and my gut and bladder have failed. As you can see, I'm in a wheelchair. But what you can't see is the line in my chest that goes into my heart, the tube that goes into my stomach, the stoma bag on my abdomen, and the catheter going into my bladder. You won't see the medication and nutrition being pumped into my heart, or the body that struggles to do even basic things. You can't see the pain, the fatigue, my racing heartbeat, or low blood pressure. Though you will see me with a smile on my face, hiding all those horrific things going on inside my ailing body. So despite their conditions, like all young adults, they aspire to regular young adult goals. Many hope to attend post-secondary education, have meaningful work, vocation, or volunteer opportunities, and live independently. However, these young adult dreams are on a collision course with their end of life, as many will die before they reach their 30th birthday. So these young adults definitely face extraordinary challenges to live ordinary lives. This new patient population of palliative young adults is growing because of earlier diagnosis, improved treatment, and management that lead to longer rates of survival. The actual number of youth with life-threatening conditions in Canada is not documented, but in the United Kingdom, where there is much more work being done around palliative and hospice care, their population has nearly doubled since 2002. The improved therapies and technologies, which are not curative, delay the onset of symptoms to their young adult years. So this group is highly complex. Their symptoms are progressive, and they reach a crisis and become unstable in young adulthood, just when they're transferring from clinicians with expertise in their condition to those that do not. So for these young adults with life-threatening conditions, their life is a paradox. And so, for example, in terms of medical improvements in care, the advances in technology and healthcare provided in their childhood that have increased their life expectancy. But there are no comparable health and social services to support their complex and palliative conditions in adulthood, resulting in healthcare providers that are providing reactive rather than proactive care. And these young adults require proactive care to ensure timely, planned, and coordinated care. And this includes discussions about the meaning of their changing symptoms for their quality of life, their approaching end of life, and decision-making about life and death decisions, like whether to be ventilated when they're no longer stronger to breathe on their own. These young adults' experiences increase their vulnerability, their morbidity, medical crises happen, and unplanned deaths occur in acute care hospitals or extended care facilities rather than their home or age-appropriate hospice that would have supported them in their childhood or teen years. Other paradoxes they experience are that their hopeful futures are imposed on progressively declining conditions, and their end of life can come precipitously. Their personal aspirations collide with their end of life trajectory. And you can see on the diagram that the upward direction of their desired young adult goals collides with their actual health trajectory on the downward direction. And most ironically, the palliative, respite, and hospice supports available during the pediatric years are not available in the adult system when they'll be needed them the most. And that's because young adults with pediatric life-threatening conditions do not fit within the mandate or philosophy of adult palliative care, which currently focuses on the last weeks or months of their life. Also, young adults don't fit into the culture of adult hospice. Young adult hospice care includes getting together at a bar, going to concerts, hanging out in groups. This is quite unlike adult hospice care, whether it's community-based or provided in a specific type of building. So the question is appropriate care a luxury or necessity for this population? When young adults leave, with palliative conditions, leave pediatric care, they face several problems in the adult system. They lose contact with healthcare professionals and coordinated health services to manage their unpredictable disease trajectories, resulting in increased risk of deteriorating health. And there's a dearth of healthcare professionals that are proficient in anticipating their expected disease trajectories and are able to coordinate their care. But it's not all about health. it's about a lot of other things for these young adults. When they're not symptomatic and feeling their symptoms, it is all about living their life. And there is no interconnectedness of the requirements they have for their health with education and social support systems necessary for them to have life meaning and personal connectivity. Like other young adults, they want to be meaningfully engaged with their peers and their community. In the social system, they experience isolation. They're no longer in school with their high school peers. They aren't at teen groups with other young teens or young adults that have similar conditions to theirs. Their friends from school are moved on, they're busy with their next stage of life. These young adults are isolated because they're either living with their parents and unable to access the circles of connection that they were part of while they were in high school, or their parents are not able to continue to care for them, and they live in extended care facilities with residents who are 5 or 6 decades older. And that's absolutely no community that is related to young adult life. And while if they're not able to live with their parents because their parents are unable to continue to care for them, their preference would be to live independently. But it is very difficult for them to secure funding to be able to do that safely. So without the kind of specific social supports that they might have experienced in their child and teen years, many have few opportunities to actually live life firsthand. The support of teen groups at pediatric hospitals gave them opportunities to do things they wouldn't have had a chance to do otherwise, like going to camp, hanging out with their friends for a weekend, having a ride in a fancy sports car, or even having the support to be creative in music or artistic endeavors. So without these supportive networks that they might have experienced in their teen years, they now become voyeurs of young adult life and what other young adults can do, like going to concerts, hanging out with friends at a party or bar, and traveling. In terms of being connected around work and volunteer opportunities, they experience barriers from employers and also from volunteer and charity organizations to become involved. In terms of education, there are problems with access which are universal, such as the availability of suitable washroom facilities and financial support for personal care attendants. And in addition to financial costs of achieving going to school and post-secondary education, there's a really significant personal cost for them to pursue their dream of going to college and university. While they're there, time to hang out with friends and family is compromised while they focus on their study. And as one of the young adults told me, she said, "I'm not like everyone else. I don't have my life ahead of me to look forward to doing the things I'm missing out on now." So what do the needs, what does young adult palliative care look like? The needs of young adults with life-threatening condition are different than the needs of older adults at end of life. And although specialized palliative care is receiving increased attention as our aging population seeks to avoid a painful and undignified end of life, this specialized palliative care is currently practiced within a very narrow time period at the end of life. In contrast, young adults with life-threatening conditions most often require a palliative approach to care that better matches their chronic disease trajectories that consist of a series of declining plateaus over a period of months to years, and they're punctuated by unpredictable periodic crises. In this palliative approach to care, professional disciplines, community organizations, and volunteer sectors join together around a common set of goals that include health, well-being, and social context. And for young adults with life-threatening conditions, these resources will support their personal, health, social, vocational, and educational goals in their quest to maximize their opportunities in an abbreviated time frame. So here's just a few ideas about recommendations for change. And first would be that, like all transition for youth, successful transition requires policy approaches that move beyond healthcare needs and recognize the full range of young adult and developmental needs. It's been demonstrated that nurse-led multidisciplinary teams provide the most effective clinical programs for patients with chronic and complex conditions requiring complex solutions. And this includes the infusion of a palliative philosophy into primary care. So instead of being a palliative approaches being designated to specific specialists at the end of life, an encompassing approach to care that considers quality of life, personal preferences, and life goals is moved down the train from these specialized tertiary care programs into primary care, so that young adults and others with these type of chronic and episodic trajectories receive this holistic approach to their care rather than an episodic management of presenting problems. Recommendations also include education and consult support for adult acute and community care providers. These conditions are rare and unknown, and adult practitioners will not be aware of and not been educated about these conditions. So it's important to provide the consult support that they need wherever they're looking for these young adults. And further, it's important for the clinicians to appreciate the complexity of factors that are contributing to their health versus limiting their attention to disease-specific outcomes. So in BC, we are in the very, very early stages of developing young adult-specific palliative care. In fact, what I'm going to describe is part of a proposal that we are hoping to receive funding for. Our goals are to provide specialized care and consultation to bridge the gaps in care and services for these young adults, and also to build a community of support for their journey ahead. And it's our strong belief that having grown up in the pediatric health system and experienced the challenges of transition and adapting to an adult care health system that was not designed and neither is it equipped to meet their needs, these young adults have an invaluable perspective about practice and policy initiatives that will improve the systems that provide them care. So our plan is to begin a dialogue with young adults with life-threatening conditions by engaging them, their families and caregivers, health and community professionals in activities like concept mapping that can shape the support provided in a palliative approach to care. We'll be listening to their ideas about ways to improve palliative services and their priorities for improvement to determine a strategic direction for care. And as I mentioned, these plans are preliminary and really are in the blueprint phase, but we are very excited about some momentum that's beginning to build. So in conclusion, I will finish off this presentation with this picture that's taken by one of the young adults in my study. And when asked a question, she said, "This picture is like my life. While the journey ahead is uncertain, I do anticipate some beautiful moments." And I have an enormous admiration for the strength, the perseverance, and the wisdom of these young adults. And this work is dedicated to them, that with the intent by telling their stories, transformative system changes will support their courageous and creative life investments. So thank you for participating and being part of this, and I look forward to dialogue with you about this.
Thanks so much, Karen. That's a very different perspective, very different view of the transitions we've been talking about, and it really, I think, will resonate with many people. We talked before, our complex care group would also be very interested in this concept of a palliative program for this group. Does anybody have any questions or comments for Karen?
It's Elaine, Karen, and that was it was a fantastic presentation. Thank you for that. I'm just wondering, as Lisa, really just said, your presentation this afternoon is a little bit different, and so appreciated because of that by little bit different from the types of transition presentations we've had to date. You bring yet another reality to the topic, and instead of it's not a comment, it's almost a question and perhaps some advice from you. CAPC's Transition Community of Practice is focused on developing standard guidelines that can eventually be taken up at a system level and adapted in different settings across the country, all sort of within that broad transition from pediatrics to adult care. And that's at the tertiary level, community level, right across the continuum of care. Do you have any advice for us or any thoughts on maybe some specific gaps or that can be addressed by guideline work, perhaps, to address some of the really compelling realities that you presented in your presentation?
Well, thank you very much for your kind comments, and that's a good question. And it's really a double-edged sword. This is not a large group of patients that are moving through this, but I believe that this palliative approach to care that has a more encompassing view would be helpful across all kind of health disciplines. And maybe it's too what's the right word, utopian, to think about that possibility. But these young adults, they're so different from each other, and their family needs are so different that it really does require some individualization of their care plan and working specifically with them. But I think that there certainly are aspects of this palliative approach to care that would be helpful to infuse across all transition pieces and really understand, looking at, and I'm sure you've spoken about this a lot, that it's not just about the guidelines and checking off the medical pieces and getting the person to the right adult specialist. It's this larger view of what health is that's important to think about, because that is part of, I think, what does not or inhibits young adults from attaching into adult care from pediatric care, because in that pediatric care there was this sense that they were known as a whole person, not just as the diabetic or the person with IBD or whatever showing up at an adult kind of clinic. So
right,
that's kind of a broad answer, but I think that there would be I'd be very interested to look at the work that's been done before, and I know Mary well and have been involved with her at different stages of the on-track work as well, not so much in the last few years while I've been doing other things, but I'd be really happy to collaborate and look at the incredibly good work that's been done so far.
I think that would be fantastic, actually. And I guess just one more comment that your thoughtful answer sort of makes me think about, Karen, is if our goal is to bring the guidelines and recommendations forward to, as one example, Accreditation Canada, and that's one way for us to impact the system. That's sort of across the country. And I just mention that, though, because there may be an opportunity to look at this. It has to be from a high level, and I think that's what you're saying, because yes, this is a very small population within the group that we're very committed to, and that's those young adults adolescents who are transitioning. But at the same time, I think perhaps there could be a few recommendations or guidelines suggested to serve this population.
Yes, yes, yeah.
And I just for a continuing thoughts and discussion, at least I'm just suggesting maybe we put that out there for thought.
Sure.
Yes, And this population can also be instructive into the adult world, because there are many older adults that are similarly medically fragile, vulnerable, and don't fit into the current palliative philosophies and are dying. There's been so much attention around end of life and the palliative community trying to let people know, well, there's only less than 20 or 25% of the Canadian population receives the kind of support that they need at end of life. So the lessons we learn from these young adults can also be applied and moved up the stream as well into older adults as well. And so services don't necessarily need to be so unique. I think there's young adult characteristics of end of life that are very different than people who are much older, but there are some aspects of it that could be transferred and shared for sure.
Exactly. Yeah. It's really, really helpful, Karen. And again, what a fantastic presentation.
Well, thank you. It's wonderful to be able to share it. I don't know a lot of people that are interested in this particular population, so I get a bit giddy when I meet other people that are interested in sharing this work.
So this is Lisa again. I'm just wondering, Karen, do you know of any work internationally that's, like we're saying in Canada and maybe the States, we're not aware of anything. Do you know of any work elsewhere that is similar, or are there other things?
I do, and I was very fortunate. I'm just a recent faculty at Athabasca University, and I was funded in January to go to Oxford, England, where they had the first ever young adult hospice conference. And I walked into a room of 150 or 200 people that were all interested in young adult hospice. So there is a lot of work going on in the UK, and they have both models of like a young adult hospice, which is the sister or brother community to Helen House, which was the first ever pediatric hospice. And because they're so geographically close there, they have, probably just in England, half a dozen, maybe more, young adult hospices that are bricks and mortar buildings where people can go and get support. But more interesting to me are the hospices that have developed a community approach to care. So the care team is in a strip mall office, and they go out and they provide hospice and support to the young adults and their families in their homes. And even though they don't have a place to bring them to, they have jumbulances, which are these big coaches that they can accommodate, these power wheelchairs and all the equipment. And they go to events that these young adults would never get to on their own, like the kind of concerts that young people go to, and they spend the weekend. They go with these young adults in their power wheelchairs and their ventilators and their feeding tubes and their lift devices. And they set up a big tent, and they spend a night overnight at these concerts, and they do things like this that engages young adults in their world. Of other young adults and what their priorities are in a way they wouldn't ever experience, and that's done even without a bricks and mortar kind of place to do that. So they are farther ahead, and I've set up some good network connections. So as we move forward and fall in the ditches, they'll be great because they will have already fallen in those ditches and can help us figure our way out. So it really is the UK where there is the most development around young adult hospice.
Wow.
Great. Does anybody else have any other thoughts or questions or experiences?
This is Deb Zool from the Alberta Children's Hospital. I just wanted to thank you, Karen, for sharing your work with us, because I think this is, often a population that really struggles, and we can focus on the medical transfer of care, but I think that holistic psychosocial, vocational, educational, quality of life approach, I think, is something we really need to start to look at. How can we do that better? And I know one of our challenges is oftentimes housing and residents and that, if the condition progresses to the point where they can no longer live at home with their parents. But I also think that there's huge gaps in terms of, what are they going to do post high school? what's going to give their life meaning and purpose. And so I think that that's a really important aspect. So thank you for bringing that up and, discussing the holistic. Those of us who kind of deal with transitional time think of it that way, but, we can also get pretty narrow in where is the medical care going to be transferred and forget about some of those other pieces. So thanks for bringing that back to us.
Well, thank you. And, the medical care is so important. It's fundamental. But to the young adults, it's about their life. If they don't have the medical care, then they can't do what they want to do. And for these young adults, when they're symptomatic and they have to wait 6-9 months to get to see a specialist, well, that takes away all their energy and ability to make the application to get into college or to try and figure out how to get meaningfully involved in the community. So while it's not all about their health and medical care, it's fundamental to them moving forward with their young adult goals. And if they get delayed 6 or 9 months, then it might mean they never get to do it either. It might close that door of opportunity for them. It'd be great to have more conversations. For me, it'd be wonderful. I work with a small group of clinicians here in Vancouver, but I would be delighted to hear other people's experiences because they shed light on ideas of ways of doing things differently in our own communities.
Yeah, it definitely makes me aware that I need to follow up with our palliative care team and have conversations in terms of what are we doing and how can we do it better. So,
Yeah.
thank you.
Yeah, thank you.
Okay, thanks very much, Karen.